go through my lecture into definition of somatization, why it is important to talk about it, who is at risk to develop somatization, what are the diagnostic features which is suggesting somatization, how you are going to manage, and finally, problems encountered during your management. What is the definition of somatization? Somatizing patients are a group of patients who present with unexplained, persistent, and multiple physical complaints. So the physical complaint by the patient would not explain it by physical examination, by history, physical examination, and investigation. Usually, these physical symptoms occur in response to emotional distress or difficult life situations. For example, the patients will complain of headache, backache, or whatever due to exposure to these emotional distress, like, for example, divorce, marriage, or a change of job, or traveling to a new situation, or working in a new situation. So the patient, if he is prone to develop somatization, he will express it in physical complaint. It is often goes unrecognized. Why it is goes unrecognized? Because most of our doctors, during their training, they train well to know about organic diseases, but they are not well prepared to identify psychiatric illness or somatizing illness or social problem. So most of us are left unprepared to deal with this situation. Okay, the somatizations occur in spectrum, range from mild stress-related symptoms. Patients may be complaining just of headache due to some emotional distress, to severe debilitation. Patient may not even go to his work, would not walk. Should I continue with this? Can you call somebody? Relevant to your practice or not? In primary health care center, how many patients you face somatization in your practice per month? What do you think? It's common or not? How many patients do you see per month? Or per 3 months? Per day. Per day, okay. How many patients do you see?
At least 5% of the patients that they do have, they come and complain of vague symptoms with no organic disease.
Okay, it's quite common. A lot of data shows that somatizations is a quite common. Some of the studies shows that 26% patients with attending primary health care center are somatizing. So it's somatization. So quite common problem. Okay, it is not only a quite common problem, it's also a costly problem in terms of time. Will take a lot of time from the patient, from the doctor, for examination, or history, or conducting investigation. So it will cost a lot of time. The study showed that somatizing patients are cost 9 times greater than the cost generated by other medical problems. So it is a costly problem. It is not only the cost matter, but it's also it change or it cause severe limitation of the patient life. The quality of life of the patient will also change. Okay, the quality of your patient life is not to change. Your job as a doctor is not only to discover the disease, but also to treat the disease and illness. And there's a big difference between disease and illness. Disease is whatever organic killed under it, an organic cause. But illness, you can put organic and non-organic diseases, like psychiatric disease or social disease or whatever. Okay. What about epidemiology? As I told you, the illness is present in 14% of a patient attending a primary health care center. Another study shows that present in 26% of patients who is attending a primary health care center. It is more common in female than male. It is an Australian study, maybe because the male, especially our female, is under a lot of stress, whether it's social, occupational, or whatever. Okay? They mentioned that it is more common in middle-aged group. Okay? It is more common in Asian, Chinese, American, more than white population. Okay, what about etiology? What do you think the etiology of
Unknown.
unknown? It's a true answer. It's unknown. But there is estimated factor, like non-psychiatric factor, including genetic and family factor. If the variant of the child is somatizing, having a somatizing character, their offspring have the chance to develop somatization. The psychiatric syndrome play a big role in somatization. They mention that 60% of patients with somatization have also an anxiety, and 50% somatizing patients also have depression. So it is maybe the cause or the effect, we don't know till now. Other psychiatric factor which could give the chance of developing somatization is early developmental abuse, whether it is physical abuse or sexual abuse in the early childhood. Also, witnessing a violence, like a crime or car accident. Personality disorders, like passive-affective and antisocial personality disorders, are more prone to have somatization than other populations. How you are going to diagnose somatization? How you are going to diagnose it? Is it easy? And somatization from definition احنا قلنا هنا ايه؟ Physical symptom, unexplained physical symptom. Physical symptoms may mimic a lot of organic disease. Sometimes you cannot differentiate whether the patient is somatizing or if he has a real underlying organic disease. So it is not an easy matter. It is often diagnosed or excluded because the symptoms may mimic a lot of organic disease. But it is more effective to give a diagnosis of somatization with the patient present with typical feature of somatization. You agree with this statement? It is more effective to purchase positive diagnosis of somatization with the patient present with typical feature of somatization.
Yes.
That means you say, top of the list of my differential diagnosis is somatization. Second, ischemic heart disease. Third, like this. Is it practical to stay like this? The answer is yes and no.
No.
If you see the patient for first time, first time, you don't know about him, like a doctor working in emergency department. Okay? He sees the patient for the first time. Then he has to exclude other underlying organic disease by health history, examination, and physical investigation. But if you are the primary health care doctor who give usually the comprehensive care, continuous care for that patient, you know the patient very well. You know him if he is somatizing or not from his file, from his report. Okay? You can give a positive diagnosis of somatization for the first time if you have continuous care with your patient. If you see the first time, after the medical history examination and investigation. اوكي. اي احد عنده اعتراض على هذا؟ طيب هل somatizing patient immune to develop an organic disease? Even if he's somatizing to you and you know him is somatizing patient, you should put in your mind, always should put in your mind the possibility of having underlying organic disease. Okay? These are the type of symptoms which usually present with patient somatization. Look at it, you will see GIT symptoms, vomiting, abdominal pain, nausea, pain symptoms, reproductive symptoms, cardiovascular symptoms, pseudoneurological symptoms. Okay, what are the diagnostic features which suggest somatization? If symptoms are multiple, I mean by multiple more than 3, and occurring in different organ systems, and symptoms are vague or exceed objective finding. What is the meaning by vague or exceed objective finding? Can أي أحد يديني example of this? If the symptoms are multiple, more than 3, occurring in different organ systems that are vague or that exceed objective finding. I will give you an example. If a patient presents you with nausea, loss of appetite for more than 3 years, okay, and insomnia, inability to sleep for more than 2 years, and she told you this is a very chronic problem. While you are looking for her, is laughing, very oriented, she is obese. You look for into her record, her weight is not that much reduced. Then that will indicate that her symptom is exceed your objective finding from history, from medical examination. Then you can say this patient may be somatizing. Okay? The other criteria is chronic course. It should be more than 2 years. Other factor which also suggests somatization is presence of psychiatric disorder. As I mentioned before, 60% of somatizing patients have anxiety, 50% has depression. You have to look for that factor. Also, a history of extensive diagnostic testing also indicate that your patient may be somatized. Usually those type of patients jumping from one doctor to another doctor, doing a lot of investigation, wasting resources, but this is a hint or a clue that patients may be somatizing. Rejection of previous physician. They are always rejected by physician because they are wasting time. My physician, they are wasting time and wasting resources without a good outcome. So they are always, or most of the time, they are rejected by other physicians. If you have a history of that, then somatization is most probably that feature. So how are you are going to evaluate a patient with somatizations in primary care setting? Step 1, you have to evaluate for organic medical condition. For every patient, you have to think for carefully history, you have to examine carefully physical examination, and if you think you have an underlying organic disease, you should investigate. You have to evaluate for the presence of psychiatric condition like anxiety and depression, because this is a part of somatization. Or somatization is a part of this depression and anxiety. You have to look it and treat it if it is present. Then if you exclude, if you go through step 1 and step 2, then you have to give a positive diagnosis of somatization. practical management point. You have to remember, for each patient of somatization, you have to remember this principle. Principle number 1, you have to develop a concerned attitude for your patient. You have to develop a concerned attitude about your patient. If your patient think that you are a trustful doctor, this could reassure him that he is on honest hand and he will not jump to another doctor. How you are going to develop a concerned attitude? By building a good doctor-patient relationship. How you are going to develop a good doctor-patient relationship? How you are going to develop a good doctor-patient relationship? By listening carefully to the patient, giving him a sense that he is not neglectable, giving him a sense that you will take care of him, giving him a sense you will not reject him, and this will have a lot of benefit to you and to your resources, okay? The second principle is to discuss the diagnosis and provide acceptable explanation of the symptoms. What do you mean by discuss the diagnosis? Is it important to discuss the diagnosis with your patient? How many doctors discuss the diagnosis with his patient? Or just you examine, you take history, you examine and conduct investigation and that's all? For every problem, you should discuss the diagnosis with your patient. Because you are the master, I know you are the master, you know the pathophysiology of the disease, you know the anatomy, physiology, pharmacology, you know everything. But your patient is a master of his problem. So if you don't discuss the diagnosis with your patients, they will not continue with you. Okay? What you are going to tell him about the disease? If you say to him somatization, he will accept it or not?
No. At the beginning, no.
At the beginning, no. Most of the patients will not accept the diagnosis of somatization because somatization is a term, it's not a diagnosis. Okay? So he wants from you to give him a term which explains the symptom he has. Okay, what other term you could give him instead of somatization? Okay, according to the symptom he has. Example?
For example, for the GIT symptom, we say your stomach is having some irritation or contractions or something like that.
Okay, if the patient is complaining of, for example, abdominal pain or complaint, abdominal pain, flatulence or whatever, you can say to him, you have a thing or a variable of, for example, irritable bowel syndrome. It's not an irritable bowel syndrome, but it's a variable of نوع من irritable bowel syndrome. Okay, he will accept this term because it's a common term, شائع. Okay, if he is complaining of fatigue or joint pain, you can tell him if he has even if there's no character of fibromyalgia, you have a variant of fibromyalgia. He will accept that. Why it is important to tell the patient the term who is within his grasp of mind? A lot of study shows that 19% of a patient who received a diagnosis for their symptoms, they will resolve. Okay, so you have to give them a name for their condition. Okay. The third principle during your management is establish a reasonable treatment goal. You have to put a goal to your patients, and what is that goal? It should be a realistic goal. Okay? So the goal with your patient is care, not cure. Care, not cure. According to Baraski, he mentioned that there is no pills to treat somatization, and no surgery to excise it. And one of the character of somatizing patient is the need to be sick. They are always need to feel that they are sick. This is one of the character of them, okay? So you have to tell them that our objective is care, not cure. Your aim is to reduce the suffering and make him more functioning on his life. The fourth steps in managing somatization is scheduling regular and brief visit. يعني ممكن تديله according to the severity of somatization from 1 to 4 sessions per month for 5 to 15 minutes according to the severity of somatization. Why we are going, what is the importance of scheduling a regular visit is to allow the patient to receive attention they need. Okay? Because one of their character, they need to get attention, whether it is primary gain or secondary gain. So by this visit, you allow them to receive the attention. The second benefit is to make sure there is no life-threatening condition is developing by history, by examination. And the third benefit is to reduce the frequency of ER visit and telephone call. What should be done in this visit? You should listen to any new symptoms. You should conduct a brief medical examination. And during this visit, you start to explore the hidden agenda, the psychosocial factors, because this agenda is not usually present. You could not explore it in the first time. You should build a good relationship with your patient to explore such an agenda. And you have to have a good communication skill, okay? How you are going to explore this hidden agenda or psychosocial stress, because we are mentioning that these physical symptoms occur in response to emotional distress. So how you are going to discover it, one of the way is back technique. Be referred to background. For example, you are asking him, what is going in your life? What is going in your life? Okay, my wife asked for divorce. Affect, how do you feel about it? I feel very sad, depressed. Okay, trouble. What trouble you the most about this situation? Okay, the children, they are asking about their mother. They are always crying. They are not going to school. I have to take situation, the home responsibility. I could not go to the work. And this is all this trouble, which put the patient into stress, and that stress is explored into somatic complaint. Okay, how are you going to handle the situation? I will try to contact my wife again. I will try to resolve the conflict. You are in the chair of not giving the solution to your patient. But if you explore this, your patient will ventilate. He will feel better. He will reduce his stress or her stress or anxiety by ventilation. And finally, you have to be empathic with your patient. By telling him this is really a tough situation. I understand that. Okay. The fourth principle you have to remember during managing patient with somatization is to educate your patients. You educate him about the disease. You educate him about why he feels the symptom and other people does not feel the symptom if they both in the same situation. You can answer this question by saying you have a low threshold for a minor trigger stimulus. For example, I could not feel my intestinal movement, but you feel it. I could not feel my heart, or I could not feel my heartbeat, but you could feel it. That's why you complain of chest problem, okay? You have to educate him about pharmacological treatment of comorbid psychiatric disorder psychoeducation and psychotherapy, and I think you will take a session about that. You have to recommend lifestyle recommendations, example, exercise, because exercise will shift the patient from his stress surrounding into more enjoyable time, okay? And he will feel more functioning, more active in his life. You could try benign treatment, although this benign treatment has no evidence base, but you could try it, and it is much better than referring a patient to another doctor or wasting the resources or exposure your patient to a lot of investigation, which is dangerous or unnecessary. So you have to try it first. You have to try hot and cold bags, for example, bandages, scans, acupuncture, and massage. These are some problems which are encountered during management of somatizing patient. The first problem is setting unrealistic goals. يعني مثلا تقول I will cure you. Okay? This is unrealistic goals. You could not. The other problem is the presence of comorbid medical condition. And if you diagnose your patient as somatizing and you don't look for possible underlying medical conditions, you'll be in trouble. So don't make the stigma of somatizations prevent you from looking to underlying medical causes. The other problem is request for diagnostic study. For example, if the patient is demanding and asking you to do a CT scan for headache, for example, he is worried about brain tumor. And from your history examination, you told him, I'm sure you don't have it. His answer, how do you know? You don't do a CT scan for me. Okay, this is a problem. But if your patient is saying this, you can tell him confidently that from your history, physical examinations, I'm sure that you don't have. And don't worry, there is another visit will be in 2 weeks or 3 weeks, so if any symptoms arise or new sign I see, I will refer you immediately. Okay? The other problem is request for opiate analgesic for pain. You can tell your patient that opiate analgesic, like for example morphine sulfate, is not good medication because it causes addiction, causes constipation, and sometimes confusion. And you have to try another simple treatment like non-steroidal anti-inflammatory drugs or acetaminophen or whatever. Frequent telephone calls is another problem from somatizing patients. If you have 2 or 3 somatizing patients among your patients, they will turn your life upside down. They will call you every 2 or 3 hours, some of them. So you have from the beginning to set the limit for call to your patient, okay? You can tell him, you can call me 1 or 2 twice between visits or not more than 10 minutes. Other problem is frequent visit to the ER. Because they always need to get care from doctors, they usually go from one doctor to another doctor, including ER. And that is the benefit of putting frequent visit in primary healthcare center to prevent those patients going into an ER. If the patient is escaped to ER, this is a very big problem because the doctor in ER, they doesn't know about the patient, and maybe they give him a diagnosis, so the patient will not trust the family physician or member, and that diagnosis could be not right, okay, because he doesn't know the patients from the start. I will tell you one story about that. There's one patient, she's 25 years old. She came to me. This is the first time to me to contact the patient, and I referred her immediately to مستشفى الملك فهد for appendectomy. She went there, and appendectomy was done for her. Okay, they diagnosed her as appendicitis, and appendectomy was done for her. Next day in the morning, I told my colleague, she knows that patient very well. I told her, I referred one patient yesterday, she had appendicitis, her name is like this and this. She told me, I know this patient. She complained of the same thing since 5 years. And she is not having any appendicitis, she is just traumatizing. But you see the difference between the primary care physician and the emergency. I'm not reducing the qualification of the emergency doctor department, maybe better than us, but because the type of patient, the care of patients needed by family physician should be given by a family physician, because those family physicians are the doctor who can give the care needed to those patients. Thank you. Do you have any question?
Thank you, Dr. Ahmed, for this lecture. Very interesting subject. My first question about the duration, 2 years. It is continuous or about acute attack?
Could the care continuous or acute attacks? Not necessarily to be continuous. It can occur on about.
Okay, second question about somatization in Arabic. What does that mean?
الأعراض التجسدية أعتقد الأعراض التجسدية. جسمنا.
Psychosomatic disease.
عربي بالعربية.
جسمنا يقول الدكتور عاطف وأعلم مني، بس أنا أعتقد إن الأعراض التجسدية.
طيب what about somatization in pediatric age group? From which year can be started?
Well, I don't face like this, but you can suspect it if the parents are somatizing patients, then the child, they will take the same pattern of expressing symptoms.
Thank you.
دكتور أنا معك في إنه في عدم تفهم من الناس سواء كانوا administrators or patients. طبعا هذه المشاكل لها chronic يعني chronic duration، فمو من السهل إنك تحل مشكلة في يوم أو يومين أو سنة أو سنتين.
المسؤولين انا خليك
مش حتى من المسؤولين، حتى من المسؤولين مو سهل انك تغير change or habits. It is not an easy matter. بس هذا ما يخلينا نوقف ونقول انه ما نقدر نغير وما حنغير وما حنسوي، لانه في مشاكل حتى لو انت مشيت في الطريق اللي هم يبغوا، برضه لو هيشتكيك شيء ثاني. يعني اللي بيشتكي حيشتكي في هذه المشكله او في غيرها. فالحل انا اعتقد انه الصبر، هذا واحد. اثنين، ان نبدا نعمل education للبيبلز للادمنستريتورز في طريقه التعامل مع الاطباء، في طريقه التعامل مع المرضى. حتى المريض ممكن ما يسمع كلامك من اول مره. على قولك انت بتشوف 40 ل 60 او ل 80 patient، ف very difficult to build a good relationship with the patient within مثلا. لكن الكرونيك فيزيت هذه ممكن تخلق علاقه وديه بينك وبين المريض. ما سمع كلامك هذه المره، معليش سامحه. المره الثانيه كرر عليه، اديله ليفليتس، اعرض عليه شرائط فيديوتيب، جمعوا الناس حاولوا ولقوا مثلا حاولوا في اذر ميديكيشن ولقوا نفس النتيجه. فحيكون الكلام كده مركز ويكون من ناس لهم تجربه وتقدر تحلها. تحتاج تايم، انا معك، وتحتاج صبر، انا معك، الله يعينك. طيب
اخر فرصه طلب محاضره وبعد كده الدكتور.
Madam, whenever you got the patient, you think as a psychiatrist that he's a psychiatric patient. If a patient of appendicitis, you stay for 5 years. If there is real appendicitis, what can you do?
I told you, don't make the stigma of somatizations prevent you from listening to your patient again, examine him again. If you find even single clue that your patient have an organic disease, refer him immediately. No need to wait. Okay.
السؤال من فوق.
تفضلي يا دكتور.
على حسب تحقيق كلام الأخ، نحن المراكز الصحية واخدين كورس كان في الجودة النوعية. فالجودة النوعية بدون تعليمات نحن لازم نمشي عليها. فعلا بنمشي نحن على التعليمات دي، لكن الضحية بنبقى نحن. البيشنت مثلا انت تكتب تسجيل وكتبت على البيشنت
هي حكايه الاوراق الكثيره صراحه دي مشكله في كل برايمري كير هيلث سنتر، يعني احنا نكتب 100 ورقه لواحد مريض. يعني المفروض تنحل هذه المشكله بالرفع للمدير عام الشؤون الصحيه ونغير. يعني احنا لو عملنا اضراب شامل بمراكز الرعايه الصحيه الاوليه عن كتابه الاوراق ممكن يشيلوها، لكن الكل بيعمل نفس الطريقه وما اشوف منها بنفيت صراحه، يعني ما اشوف منها اوت كم كبير.
يعني احنا لو ما كتبنا مشكله، واذا كتبنا مشكله من البيشنت يعني ما عارفه الطبيب هنا
نعاني زيكم ترى، احنا في صف واحد يعني في مركب واحد، نحن السعوديين وغيرهم نعاني نفس المعاناه يعني، سواء في نسال الله انه يعني
بس الغريب يتكلموا خلوا الدكتوره السعوديه تقول نعم الاضراب.
طيب اشكر يعني قبل ما نروح في ناحيه يعني نشكركم جميعا.
دكتور خالد، دكتور نادية, those are the young leaders of the health society in Medina. So many things inshallah